Good afternoon, and thank you very much for the kind introduction. The topic of my lecture is Addressing the Elephant in the Room, Dyslipidemia. We bring to mind the imagery of the elephant in the room. We know it's present, it's huge, it's looming, it's potentially dangerous, but we hardly talk about it. This is very much like the problem of dyslipidemia in the country. And this afternoon, I would like to discuss with you the 2020 Clinical Practice Guidelines on Dyslipidemia. This is my disclosure of conflicts of interest slide, and I'm happy to present the 2020 Evidence-Based Practice Guidelines on Dyslipidemia in the Philippines on behalf of the members of the Technical Research Committee, which is headed by Dr. Luella Gonzalez Santos, the current president of the PLAS. This is the outline of the discussion. First, I'll talk a little bit about epidemiology, then proceed to the specific recommendations, and end with some summary and conclusions. Now, looking at the prevalence of dyslipidemia in the Philippines, we do know that it is a huge problem. Nearly 50% of all adults in the Philippines have elevated total cholesterol. And this is compounded by the problem that, in fact, LDL cholesterol is also elevated LDL cholesterol is also found in around 50% of all adults. Take note that the cutoff is not even 100 milligrams per deciliter here, but it's actually 130. So potentially, this can be a higher number. And finally, take note as well that these are data which is nearly 10 years ago in 2013. So this problem persists, and we can see it in the way that it has made an impact on our mortality, on the 10 leading causes of mortality. As shown here, this is DOH data for 2010 to around 2014, published in 2015. So you can see that diseases of the heart and the vascular system still comprise the first and second leading causes of death. And if you take a look at the statistics last 2021 from the Philippine Statistics Authority, they report that ischemic heart disease is the #1 cause of mortality, followed by cerebrovascular disease. And in 2021, COVID is #3. The reason why we developed the 2020 CPG, and this was during the time of COVID already, was because even as we released the 2015 Clinical Practice Guideline, there was already a clamor to update it because there were many unanswered questions, some on statin safety, some on chronic kidney disease. And at the same time, there were new studies that were released and completed at that time, which then resulted to the updating of international practice guidelines, and we were not certain whether in fact these international recommendations were locally applicable. In the 2020 practice guideline, much like in 2015, we use GRADE as the system for developing the practice guideline, and GRADE stands for Grades of Recommendation, Assessment, Development, and Evaluation, which is a common, transparent, and a systematic way for us to develop actually recommendations, guidelines, and health policies. And we use the Grade Pro software online in the 2020 practice guideline. In 2015, we actually used 7 different clinical outcomes, 5 of which are critical for decision making and were scored as 9, with 1 being lowest. And this is total mortality, CV deaths, fatal and non-fatal MI, stroke, or cerebrovascular disease. The composite of major cardiovascular events, or the MACE, was still considered to be critical but only scored 7, while revascularization was considered as important and was scored as 6. So we still use these outcomes in 2020, but we added these different outcomes that involve statin safety, like hepatotoxicity or rhabdomyolysis, and which were considered as critical. Important were new onset diabetes, intracranial hemorrhage, cognitive dysfunction, scored as 6. And of low importance is the risk of dementia. And again, much like in 2015, we made recommendations that are stated this way, no? Strongly recommended, may recommend, or do not recommend, depending on the quality of the evidence and the evidence that is linked, no, to the different outcomes. So that if the quality of the evidence is high, excellent, good, and this is linked to critical outcomes with a low number needed to treat, then we strongly recommend that intervention or that test. And the opposite is true. Even if the outcome is critical, if the quality of the evidence is low, and the number needed to treat is high or not statistically significant, then we do not recommend it. And so straight away, we go to the recommendations with regards to lifestyle modification. And this is the same as in 2015. So what did we recommend for diet? We recommended a low-fat, low-cholesterol diet rich in fruits and vegetables for individuals at any level of cardiovascular risk, but especially for those with established atherosclerotic cardiovascular diseases. We also recommended to stop smoking, and of course, adequate exercise at any level of cardiovascular risk. Much like in 2015, we recommended in 2020 that we use the Pinggang Pinoy. A 9-inch plate is advised to cover this many calories, but if the person is of much higher weight, then a bigger plate is actually allowed, an 11 to 12-inch plate, with half the plate comprised of green leafy vegetables and 1 serving of fruit per meal, for a total of 4 to 6 servings of fruit per day. Now, with regards to smoking, it is the same recommendation in 2020 as in 2015, but we added that we also recommend cessation of e-cigarette smoking or vaping. And that is despite the paucity of long-term studies on the impact of e-cigarettes to cardiovascular morbidity and mortality. In fact, even plain smoking, plain cigarettes, the evidence is not very strong. Number needed to treat of 10 for total mortality, and for CV events, a number needed to treat of 100, but we still recommended smoking cessation. We did the same for e-cigarette or vaping. We said to recommend cessation of e-cigarette or vaping, do not initiate it, despite the fact that in fact the evidence is still sparse. That's the recommendation of the voting or expert panel. With regards to exercise prescription, again, this is much like in 2015. We recommend 150 minutes of moderate to high intensity exercise per week, split into 30 minutes or longer session to improve CV outcomes in consideration of age and background CV risks. Consistency and regularity of exercise is important and needs to be integrated to one's lifestyle. Straight away, we go to the primary prevention recommendations. And here, we recommend that among persons who do not have diabetes, who do not have ASCVD, but with multiple risk factors, we recommend that statins should be given. And this is among individuals who are 45 years old and above, with an LDL cholesterol of more than 130, more than or equal to 130, and 2 or more risk factors, with the following risk factors being considered: male sex, menopause in women, smoking, hypertension, BMI more than 25, a family history of premature coronary heart disease, microalbuminuria, proteinuria, and left ventricular hypertrophy. Now, this is the summary of the evidence. You can see the very low number needed to treat, especially for the critical outcomes. And in the Philippine Practice Guideline, we used actually an LDL threshold of 130 to be considered for primary prevention. And this comes from the ASCOT lipid lowering trial. And this cutoff is used to represent persons at higher risk of development of cardiovascular outcomes, even if they don't have background ASCVD, if they have other risk factors. However, compared to other practice guidelines, we do not do prediction models, not yet. And so we just count the number of risk factors. Where did the cutoff of 2 risk factors come from? It came from the primary prevention trials that only included persons who had at least 2 risk factors. the TRC did not find any data on patients with one or no risk factors. And the age of 45 came from the National Nutrition Survey, where in fact we saw that at that age group, the prevalence of elevated LDL cholesterol actually peaked. No? And although there is no recommendations for persons less than 45 years with less than 2 risk factors, individuals in this age group may still be eligible for lifestyle interventions and even for statin therapy later on. Now, how about primary prevention among those with diabetes even without ASCVD? Again, we recommend routinely using statins. In fact, if you find a person with diabetes, especially type 2 diabetes of any age, even without baseline lipid profile, you are actually justified to start statins. And this is based on moderate quality evidence from many included patients, and with 3 critical and 1 important outcomes, which showed statistically significant results, no, based on our evaluation. The other rationale for the aggressiveness in treating persons with diabetes is this epidemiologic or cross-sectional study that found that even among newly diagnosed persons with diabetes in Manila, 10% already had ECG changes and various complications which are found at diagnosis. And this is probably because persons with diabetes have atherogenic dyslipidemia with this particular profile: high triglyceride, low HDL, and their LDL cholesterol is actually similar, as persons without diabetes. But the burden or particle burden for the small dense LDL is so much more. And this justifies using statins. Quickly, just to show you therefore the treatment targets for primary prevention: those who have no diabetes but with 2 or more risk factors, 45 years old and above, less than 130 LDL-C target. Persons with diabetes, less than 100. And when the person with diabetes has 1 or more risk factors or already has target organ damage, a much lower target of less than 70. And diabetes or no diabetes for secondary prevention, the target is now much lower, less than 55. And I'll go through that in a bit. Now, the next category are for persons who have familial hypercholesterolemia. And these are considered to be high-risk individuals, and therefore should statin therapy be initiated. And the recommendation is really to strongly recommend statin therapy. FH is a congenital problem that results from these various mutations, and this leads to elevated LDL cholesterol and premature CAD. This can happen even among infants, children, young adults, And this is marked not only by very elevated LDL cholesterol and premature CAD, but physical stigmata of high LDL cholesterol. And in both heterozygous and the homozygous forms, the absolute magnitude and duration of exposure to the LDL cholesterol leads to ASCVD. So the longer you have it, the higher is the LDL cholesterol, the greater is the possibility of premature CAD or ASCVD. Once thought to be rare, the global estimates puts the prevalence at 1 in 200 to 1 in 250. Although the diagnosis is clinched by using DNA analysis, we can diagnose FH through various criteria. The one that we follow in the Philippines is the Dutch Lipid Network criteria that considers a family history of premature CAD in scoring, a clinical history, a personal history of premature CAD, and the presence of physical stigmata of high LDL cholesterol, like the tendon xanthomas and arcus cornealis prior to age 45, together with high elevated LDL cholesterol, especially more than 190. This is arcus cornealis. You can see a visible white crescent typically in the upper and lower parts of the cornea, with a clear space between the ring and the periphery of the cornea. This may grow to a point that it's actually an obvious corneal ring, such as you see here. And this is more specific for those who are not yet 45. These are some examples of tendon xanthomas: Achilles tendon, extensor tendon, the insertion of the quadriceps. No? This is in the elbow. This is in the hands, in the plantar aspect of the feet, even in, for example, the buttocks area. And just to show you some examples from patients of Dr. Santos, to show you that it happens among Filipinos, these are some examples of tendon xanthomas as well. Also, you can find xanthelasma palpebrarum, which is yellowish deposition or yellowish patches around the eyelids. And again, please take a picture of the Dutch lipid network criteria. While we are probably all adult practitioners here, we also have recommendations for the pediatric population, where we recommended fasting lipid profile in a pediatric population as screening. No? And who should be screened? Those who have risk factors like obesity, diabetes, whether type 1 or type 2, children with hypertension, family history of FH or personal history of FH, family history of premature coronary cardiovascular diseases, presence of CKD, Kawasaki disease, or HIV in the child, or adolescent depressive and bipolar disorders. The reason for this is that early identification and control of pediatric dyslipidemia will of course reduce the risk and severity of CV disease in adulthood. We recommend selective screening for more than 2 years old, so screen if with risk factors. But they also recommend internationally universal screening for those ages 9 to 11 and 17 to 21 to be able to identify those with FH. They also don't recommend screening between the ages of 12 to 16 because during puberty, apparently the lipid changes in the lipid level decreases the sensitivity of the lipid profile for screening. Moving on, for dyslipidemia in CKD, but not yet on dialysis, we also recommend that statins be given to reduce cardiovascular risks. This is very similar to international recommendations because CKD is considered a coronary heart disease equivalent, and dysregulation of lipoprotein metabolism occurs even in early stages of kidney disease, showing various lipid abnormalities in CKD being exacerbated by use of peritoneal dialysis. Other guidelines, like the KDIGO, recommend baseline lipid profile to justify initiation of statin treatment and the use of moderate intensity statins because persons with CKD are at higher risk of adverse events. Now, if they are unable to reach the target with statins, you can combine ezetimibe based on the SHARP trial, especially for those who are not yet on dialysis. For those who are now dialysis dependent, we avoid initiation of statin or statin-ezetimibe combination. But once they've been started on statins and they go to dialysis, the recommendation is not to stop the statins. Likewise, for kidney transplant, this is based on the ALERT trial, they also recommend to actually give statins to reduce CV deaths among kidney transplant patients. Now, among those with acute coronary syndrome, what is the recommendation for statins? We recommend early, high-intensity statins, or dose that is maximally tolerated, and this should not be discontinued. High-intensity statins should be, in fact, given immediately to persons with acute coronary syndrome based on the fact that when initiated early, within 5 days of acute coronary syndrome, it results in fewer CV outcomes, as shown here in this slide. And which are the high-intensity statins? It's actually the ATOR 40 to 80 and the ROSU 20 to 40 milligrams, which reduces the LDL cholesterol to more than 50% from baseline. So even if in fact you don't have the baseline lipid profile yet, you're waiting for it to come out, start high-intensity statins or maximally tolerated statins. Unfortunately, very few actually reach the target LDL, which by this time is actually not anymore less than 70, it's less than 55. No? So apparently statins are not enough. And therefore, statins can actually be combined with ezetimibe. No? Despite giving high intensity or maximally tolerated statins, you don't reach your target, then you can add ezetimibe. The same for secondary prevention among persons with ASCVD. Statins should be given, and typically it would be maximally tolerated high-intensity statins. And this is based on really a plethora of evidence. Now, other secondary prevention trials, if you are unable to control statins, what do you add? I already said, for ASCVD, you add ezetimibe. But it's not recommended actually to add fibrates on top of statins, no? Even if you've reached actually the LDL cholesterol goal. And this is the summary of the evidence for fibrates. You can see that it's all for the different outcomes. None actually showed statistical significance, except for one, which is non-fatal MI. And therefore, if you find persons with elevated triglyceride, TG reduction only becomes the primary objective when it's very high, when it's more than or equal to 500 to decrease the risk for pancreatitis. But if it's lower than that, then LDL still is the primary goal. Among persons with diabetes, the same is true. Even in diabetes with ASCVD, statins are still recommended. And it's not really recommended to routinely add on fibrates. However, fibrates may be added to statins among those already at LDL goal, among men with controlled diabetes and low HDL, and persistently elevated triglycerides. You can see from the ACCORD lipid-lowering trial that for the primary composite outcome, the two graphs actually overlap, placebo versus adding on fibrates on top of statins. And even for total mortality, the separation happened at around the 6th year, but the overall analysis did not show statistical significance, except for, as I said, the subgroup of men who already have still elevated triglyceride and low HDL. The same is true for omega-3 fatty acids. It's actually not recommended, the combination of EPA and DHA. But once the icosapent-ethyl is available in the Philippines, then this is something that we can give for those with persistently elevated triglyceride between 135 and 499. And this is based on the REDUCE-IT trial that involved those with ASCVD and type 2 diabetes with one additional risk factor, randomized this way. And you can see that even during the first year, there's a clear separation with those given icosapent-ethyl actually having a 25% relative risk reduction of the primary endpoint of CV death, MI, stroke, coronary revascularization, and unstable angina. Next, we go to the questions on statin safety. And here, the question is, what is the risk of developing these adverse events? So here it says that SAMS, dementia, cognitive dysfunction, intracerebral hemorrhage, very small nil risk of developing adverse events. And it's actually new onset diabetes where there is a small increase in risk. But the benefits of CV risk reduction still outweighs the risks. There are many types of statin myopathies, but the only one that is clinically relevant is actually rhabdomyolysis. And here it says that, in fact, SAMS might occur in, or statin-associated muscle symptoms might occur in 10 to 15% of the patients. However, only very few actually develop serious side effects such as myopathy. And so from the 2015 practice guideline, we've already actually addressed this problem. If patients present with myalgia while on statin therapy, you have the option of checking the creatinine kinase. If it's elevated more than 5 times the upper limit of normal, and the patient does not tolerate it, check for organ damage. Check the creatinine, check whether the patient has rhabdomyolysis, and discontinue the statins if ever. If there's not organ damage, discuss the importance of the statin therapy and ask the patient whether she wants a drug holiday or resume at a much lower dose. And if there is recurrence of symptoms, then consider the following. Combination therapy of a low-dose statin with ezetimibe, a low-dose rosuvastatin given alternate every other day or even a weekly dosing, or starting on PCSK9 inhibitors. If rhabdomyolysis does happen, stop the drug, give a drug holiday, and then afterwards consider restarting with low dose or low dose combined with ezetimibe or even PCSK9. For new onset diabetes, the recommendation is to the statement actually says that yes, there is an increased risk of new onset diabetes mellitus, but that the benefits actually outweigh the risks. And based on the meta-analysis on the use of statins and development of new onset diabetes, there is an almost 60% increase in risk. But these are patients who also actually have other diabetes risk factors such as obesity and hypertension. And that the risk for developing diabetes is actually dependent on the statin dose. So this is the meta-analysis. Again, if this is the line of equality at 1, you can see that all the studies are at the right, meaning increased risk. And again, it's around a 60% increase in risk. So while it's there, it can be mitigated, it can be monitored, it can be anticipated and treated. Now for dementia, use of statins is not associated with the development of dementia and cognitive dysfunction, and this is based again on a meta-analysis. So you can be assured of the safety of statins, and in fact, they appear to be protective actually against the development of dementia. For intracerebral hemorrhage, treatment with statins is also not associated with an increased risk of intracerebral hemorrhage, and this is based on many studies. But if the person by itself, even without statins, already has predisposing factors like elderly, more than 80, using anticoagulants and uncontrolled hypertension, then of course, exercise caution. And these are the different evidences that support the safety of statins as not causing intracerebral hemorrhage. Finally, we go to the novel biomarkers, and there are just 2 novel biomarkers that are recommended. So we recommend using, after you have controlled, you have reached your LDL cholesterol goal, you want to lower risk further, you can use the non-HDLC as the secondary treatment goal. You compute the non-HDL cholesterol as total cholesterol minus the HDL cholesterol. And we all know that the target for non-HDLC is 30 milligrams per deciliter above the target LDL cholesterol, because the non-HDLC represents all the atherogenic fragments, of course without the protective HDL. And again, the target is 30 milligrams per deciliter above the target for LDL cholesterol. Now, we also recommend ApoB 100 as a secondary or additional target after you have reached the LDL cholesterol goal. And this ApoB is actually an essential component of all the atherogenic lipoproteins. All these atherogenic lipoproteins carry one molecule of ApoB that facilitates attachment of these particles to the cellular receptors. However, its utility is not yet well established, as it has not been linked actually to improve outcomes and to cost effectiveness. So finally, just then to summarize the lecture, this is the algorithm for the screening and treatment of dyslipidemia for 2020. Based on the patient's history and physical exam, everyone gets lifestyle modification. If diabetes is present, then start statins. If there's no diabetes but the LDL cholesterol is more than or equal to 130, and especially if they fulfill the criteria for FH, then start statins. If it does not fulfill the criteria but there's already ASCVD, this is secondary prevention, start statins. If there's CKD, CKD is a coronary heart disease equivalent, start statins for as long as they're not yet dialysable. If all of these are absent, and so this is a true primary prevention situation, age more than 4 to 5 years with 2 or more risk factors, start statins. And if all of these are absent, then just reassess the patient after a few weeks or a few months. And then again, the treatment targets. So please remember, though, that the 20 CPG is intended to be a guide for managing dyslipidemia among Filipinos. This should not replace sound clinical judgment, and the ultimate decision for treatment still rests on the clinician speaking or consulting with the patient who is in front of him. So thank you very much for your time and attention and for listening to the elephant in the room. Thank you very much and good afternoon.